Thank you so much for that very kind introduction. I am indeed Amit Pawa, and I'm going to be talking to you about optimal analgesia for breast cancer surgery. I've inserted the word cancer into there because that is what I spend a lot of my time doing. I do have a few disclosures to discuss with you, which are all included over here on the screen. And I also wanted to remind you to use the ESRA2021 hashtag if you see anything or come across anything you find useful, and my Twitter handle is at the bottom of the page. The other thing or other bit of housekeeping is that during this presentation, I will be using QR codes to highlight useful papers or references. If you want to catch those references, hold your camera up to the screen and literally point the camera towards that QR code and it will take you to the link. You can use a QR reader app. And the other thing to tell you is that this particular QR code will take you to my SlideShare account, where after this presentation, I will upload the PDFs of these slides. So you will have access to those. Don't worry about screenshotting. So what am I going to be covering within this short talk? I'm going to be covering why I'm talking to you about breast cancer surgery. And then, of course, we're going to be talking about optimal analgesia for breast cancer surgery. And what do I mean more specifically? Well, I'm going to focus on surgical concerns, patient concerns, anesthetic considerations and concerns, and then, of course, some of the anesthetic strategies. So why am I talking to you? Well, I'm very lucky that I've had some excellent teachers. Both John McDonnell and Rafa Blanco have taught me in my early part of my regional anesthesia career. And as a result, I've had 12 years thus far of breast anesthesia experience. I've also taught a few folk who have gone on to do some good things with regional anesthesia for breast cancer surgery. And I have been lucky in that I've managed to be associated with some useful publications in the area. So let's start off with some of the surgical concerns, and I'll start off with some of the initial negative comments I had from my surgeons the first time I worked with them, and also with surgeons I worked with for the first time. They said, well, breast surgery isn't that painful. We don't need to do a nerve block. Or don't worry, I'll infiltrate some local anesthetic at the end. Or we haven't really got time for the block. This is a very busy list. Or your block interferes with my surgery. Now, I used to think that last point wasn't really an issue until we were involved with some colleagues and we wrote this letter. There are some surgical colleagues who found that a pectoserratus nerve block, or what would have been a PEX2 block, may well interfere with them being able to identify the thoracodorsal nerve or the long thoracic nerve when they're doing their local anesthetic dissections. And certainly the long thoracic nerve has been cited as a nerve that they haven't been able to identify with electrical stimulation when they've been doing their surgical dissection. So bear that in mind. What about some positive surgical concerns? Well, actually, when my surgical colleagues really want a patient to be comfortable after surgery, they'll often recommend that I do a block for a particular patient for whatever reason. Or they may well say, Amit, this patient is very high risk for general anesthetic. Should we consider doing them awake? We started doing this with my surgeons back in 2015, and this culminated in a paper which we eventually got into print in 2018. But this was a sort of, we've been doing it for a few years beforehand, and this is me collaborating with our breast surgeon to get something out there in the print to show people what was possible with just a single injection paravertebral block and pectoral nerve blocks. We will talk a little bit more about this later, but for more information, scan that QR code. So it's really important that whatever you do, you work with your surgeons. It's all about teamwork. You need to discuss what the optimal plan is, put the patient at the center of that decision, make that plan, and select the cases which you think really would benefit from having a nerve block. And what are the patient concerns that you had? Well, patients will often say, will the surgery hurt? And then when I talk about the regional anesthetic technique, they say, well, will the block hurt? They often want to know what the risks of the block are, whether they have to have a block, is it obligatory? And of course, the answer is no. They also ask sensibly what happens when the block wears off. And that's where planning pain medication due to the trajectory of pain after a particular surgery is worthwhile. There's been some work looking at pain trajectories after surgery. They also want to know whether they'll wake up during the surgery, so awareness, or whether they'll wake up at all at the end. And some of them do ask whether they have to have a general anesthetic, and the answer is, of course, they don't have to. So it's important when you're talking to patients to give them enough information and time so they can prepare for whatever it is you decide they're going to do. You must reassure them, give them a whole host of options, and make sure that you two of you come up to a shared decision. What about all of our anesthetic concerns being the crux of this talk? Well, it's really important, and I make no apology for the fact that I'm really going to go into the anatomy. We need to know the anatomy to know what nerve blocks are relevant, and then know what our patient will accept based upon risks and what our surgeon will accept. We'll know whether there are any contraindications to any of the blocks we want to do, and we need to do a full risk-benefit analysis, but we also should have a plan B or a backup plan. So now let's spend a bit more time looking at anaesthetic concerns. Now, breast surgery or breast innervation, chest wall innervation is not quite as straightforward as I remember thinking it was from medical school. It's a little bit funny. And I used to talk about it in terms of thinking about skin and subcutaneous tissue, muscles and fascia, but people never really seem to take all of that on board. So now I'm going to kind of look at it using a number of techniques. So here's a schematic diagram of the breast and chest wall. And now let's look at the dermatomes. And what this emphasizes here is that the cervical plexus innervates the top part of the supraclavicular fossa here, and also the cranial part of the breast, and also emphasizes that actually sometimes the area of surgical work may extend below T5 into T6. So if you have a very limited spread of local anesthetic, that may explain why the patients still feel the chest drain, for example, when they bring it out in the T7 or T8 territory. Now let's look at a bit more detail at the nerves. So again, here's the supraclavicular nerves, innervating the superior or the cranial part of the chest, the intercostal nerves, both the anterior cutaneous branches in red and the lateral cutaneous branches in purple. What I want to emphasize here is any surgery on the medial part of the chest wall, in the area where the red nerves are there, if you've just done a nerve block that takes out the lateral cutaneous branches of the intercostal nerves, don't be surprised if the patient experiences pain or discomfort. We then got the intercostal brachial and the medial brachial cutaneous nerves innervating the upper medial arm and the axilla, the long thoracic nerve, and the medial and lateral pectoral nerves that have become famous in their own right. Now let's have a look at an anatomy overview and seeing how these can become relevant. So if you now have a look at this point over here, you'll see here the anterior cutaneous branches of the intercostal nerves coming off parasternally and innervating the chest, the lateral cutaneous branches, and you see serratus anterior right over here. As we come round to the back of the chest, you'll see again serratus covered by LD. And now if we look at the paraspinal region, you'll see how we can access the ventral ramus as a paravertebral block or as those paraspinal variants. I do at this point want to draw your attention to this interesting daring discourse by Carlo Franco, which challenges some of these concepts. Initially, I wasn't going to recommend it, but I think it's great to read because actually it makes us think about in a little bit more detail about what we understand. But take it from me, my personal experience is the interpectoral injection is key to certain breast surgical procedures where you do require some decent analgesia. It's not essential, but it can make a big difference. So have a read of that. Now let's talk about the spectrum of surgery. So we're looking at breast cancer surgery. We've got the pure oncological surgery, just chopping it out, and then the oncoplastic component, which involves either mobilizing existing breast tissue, inserting an artificial implant, or rotating or inserting a free flap to reconstruct the breast. And all of these variants can, of course, be performed in addition to sentinel node biopsy or axillary node dissection in the axilla. The scars don't tell the whole truth because you might just look at scar and think that's not major surgery. But of course, underneath all of that, you may be having something a little bit more invasive. In this image here, we've got what would just be a sentinel node biopsy. You can see the glistening evidence there of a pec block. This patient had a mastectomy from a special incision. But you can see during that area, we actually went on to do an axillary node dissection. You can see a pectoral nerve visible here. This is a patient having a mastectomy and implant reconstruction using a dermal sling. But in these days, in the old days, my breast surgeons used to lift pec major up off the chest wall and anastomose it to this dermal sling and slide an implant underneath. You can see how that would be associated with a lot more discomfort than just the scars would suggest. So what are the nerve blocks available? Warning, we're about to enter new nomenclature territory. This wonderful paper by a whole group of international anaesthetists redefined what we should be doing in terms of standardizing our nomenclature. Scan the QR code to see it there, but I'm going to be using that new nomenclature now. So what are the blocks available? You have the good old favorite of mine, the paravertebral block. You've got the interpectoral plane block and the pectoserratus plane block. got the serratus anterior plane block, and you'll see, if you're eagle-eyed, you will notice that the superficial part of the serratus anterior plane may well share that same fascial plane with the serratus plane. What else do we have? We've got the parasternal plane block, both superficial and deep variants. We've got an erector spinae plane, retrolaminar, intertransverse process, and the rhomboid intercostal plane. There's a whole host of potential things we could use here. You may well be familiar with the terminology paravertebral by proxy or paravertebral light used to discuss ESP, retrolaminar, and the intertransverse plane block. So worthwhile bearing that in mind. So if you were to visit a breast list that I was anesthetizing on, you might see me doing, in isolation or in combination, a whole host of these blocks. The paravertebral blocks, paraspinal plane blocks, including ESP or the intertransverse process blocks, a group of anterolateral chest wall blocks, so pectus serratus and interpectoral plane, or the serratus anterior plane, and of course the anteromedial chest wall blocks, which are the superficial and deep parasternal plane blocks. So how do we decide what to do? Well, it's important to think about what these blocks cover. So the good old-fashioned paravertebral block definitely takes out the ventral or the proximal part of the intercostal nerve, and therefore you get the lateral cutaneous nerve and the anterior cutaneous branches of those as well. And if you do it high enough, you get intercostal brachial nerve. The interpectoral plane only takes out the medial and lateral pectoral nerves. So it will just take out pec major and pec minor. The pectus serratus and serratus anterior, which I've considered the same here, take out the lateral cutaneous branches and intercostal brachial, and the long thoracic nerve only. They don't take out the anterocutaneous branches. The parasternal intercostal plane blocks, the superficial and deep variants, just take out the anterior cutaneous branches of the intercostal nerves. ESP, probably, if we think it works by paravertebral by proxy, probably takes out the lateral cutaneous branch, or maybe it also takes out the anterocutaneous branches as well. And the intertransverse process blocks, because they go a little bit deeper, do take out elements of the proximal part of the ventral ramus of the intercostal nerve. So it takes both the lateral and anterior cutaneous branches. And you can use a table like this to kind of plan where the incision is going to be, what nerves are innervating, and what your optimal block might be. So how do you choose a block? Well, you've got to think about whether the patient will benefit from a block and whether any contraindications. You need to think about the incision location. Is the axilla involved? Are they on anticoagulants? And whether the surgeon will be happy to have local anesthetic in the axilla, and also whether the patient can get themselves in a position amenable to siting that particular block. So all of these elements are important. So if I was anesthetizing on a list where the patient was having a lumpectomy or minor surgery, I would generally tend to do the anterolateral chest wall blocks with the interpectoral plane and pectus serratus, or serratus anterior plane, or I would do paraspinal plane blocks with ESP and or the intertransverse process blocks. If I was doing slightly more major surgery, so mastectomy plus or minus a reconstruction, my first choice would be to perform a paravertebral block. My second choice, if it was challenging to site paravertebral or if there were contraindications, would be to do one or both of the paraspinal plane blocks. And then if for whatever reason I couldn't do one or two, I would consider blocking the anterior, medial, and anterolateral elements of the chest wall by combining those two chest wall plane blocks there. Whenever I'm thinking about axillary surgery, if they're doing an axillary node dissection, so clearing the axilla, if I had not included interpectoral plane with either pectus serratus or a serratus plane, I would consider adding it, making sure I take care of the total dose of local anesthetic. So having decided what you'd like to do for the surgery, what analgesia you'd like to offer, you then got to see the patient and make sure they're prepared. So take your time explaining what you're going to do, reassure the patient and explain what's involved. Use positive phrasing or language, not we're going to stick a big sharp needle in your back and it's going to be really painful. That's not good phrasing. Be confident when you describe what you're going to be doing, and that sets the tone for the next phase. The next phase, of course, is block insertion. So make sure when you have the patient there, use a warm blanket. It's a warm, relaxing room, maybe playing some music, smile, be reassuring and compassionate. Full IV access and monitoring, because we know these blocks can be associated with vasovagals or cardiovascular disturbances. If required, use sedation and make sure you position the patient carefully and use local anesthetic to the skin. Now, if you're going to give a general anaesthetic as part of this process, of course, use whatever you're comfortable with. My personal preference is to use propofol. I use a depth of anaesthesia monitor, and there are certain points when I know if I haven't blocked the axilla for a sentinel node biopsy, the surgeon's going there, I might increase the depth of anaesthesia at that point just to make sure the patient doesn't troubled too much by any stimulation in that area. I use it in combination with multimodal analgesia and make sure I prescribe rescue analgesia and discharge meds. There is the option for general anesthesia-free surgery, so offer it if you're comfortable doing it. It requires patient motivation, a prepared team and surgeon. You need time for the block to work. And if you're going to use sedation, monitor the depth and maybe end-tidal carbon dioxide monitoring. But some patients just manage with music, but make sure you have a rescue strategy or a backup. And my particular technique, and if you search this hashtag on Twitter, you'll see previous posts about it, is I combine paravertebral plus PECs. Make sure you visit your patients post-operatively, look at the pain scores, the opioid requirements, and whether they're needed rescue analgesia, what their incidence of post-operative nausea and vomiting is, and what their quality of recovery is like. Because it's important that we think about outcome measures. And quite often we just look at pain scores, but we don't look at the whole picture. So what do I mean by outcome measures? Well, there are a whole host of outcome measures you can look at. The classical drinking, eating, analgesia, mobilizing, but a whole host of other things that may well be relevant. But what's really important to the patient? And how can you assess, how are other ways to assess the impact of a block? Well, what about the minimum clinically important difference? So this is the smallest change that's important to patients. And you can measure this potentially by looking at quality of recovery scores, something like the QOR15. If you go back to 2011 and 2014, there were studies looking at paravertebral blocks with quality of recovery. So when you compared paravertebral with a general anesthetic alone, paravertebrals were associated with a higher quality of recovery. When you compared paravertebral with propofol general anesthesia versus a sevoflurane general anesthetic alone, the quality of recovery was higher in the paravertebral and propofol TIVA groups. What about something more recently? In 2021, there were 68 patients, this is from China, having a modified radical mastectomy under a volatile general anesthetic or general anesthesia with sevoflurane. They all got paravertebral injections, but half of them had ropivacaine, the other half had saline, and the quality of recovery 40 was higher 24 hours later in the group that had paravertebral blocks. That's nice to know. What about PEX2 blocks, as they used to be known, and quality of recovery? So this study now from 2020 compared PEX2 blocks with local anesthetic infiltration. And actually, they found no difference in quality of recovery from relatively minor surgery, but only 12 out of 104 patients had mastectomy. So the majority of patients didn't have major surgery. This was a paper now from 2021 from the Canadian group here, looking at deep serratus anterior plane block versus placebo. And they didn't find a difference in quality of recovery, pain scores, or opioid use for patients having minor surgery, about 40 of these patients. A letter, however, was written in anesthesia noting that both groups had about 50 milligrams of IV morphine and a large dose of oral morphine post-operatively, and they only used 20 milliliters of local anesthetic, which is almost certainly less than the original study description for serratus anterior plane. This is now a paper from 2021 looking at non-mastectomy surgery, and they showed that analgesia was better with paravertebral block when compared with the deep serratus block. So actually paravertebral blocks are probably trumping the fascial plane blocks in many of the papers I have seen recently. But is this the whole picture? And actually probably isn't. So we just had a look at 100 patients at Guy's and St Thomas's who were having breast cancer surgery. We did pre and post-operative quality of recovery scores, and we noticed that actually, compared with no block, having a block was definitely associated with a higher quality of recovery. But the best of those performers were patients who had paravertebral blocks or a combination of blocks, who in fact had an improvement in their QOR scores in nearly all parameters. And actually, what was interesting is a combination block. Majority of the combination blocks included erector spinae plane block plus an intertransverse process block. So I have been doing this supercharged ESP recently, where I do a standard erector spinae plane block, and then I do an intertransverse process before or after the injection to kind of consolidate or get a deep block at that level. So maybe that's an option. So we also have some guidance from Prospect who say that we should be using multimodal analgesia and use preoperative gabapentin, IV dexamethasone, and opioids as rescue. they do actually recommend paravertebral as a first line and PEX blocks or interpectoral and pectoral serratus blocks as a second choice, despite the fact there are some meta-analyses that show that PEX blocks may be the same, if not superior to paravertebral blocks. And they'd also mention that we can add in surgical infiltration if required. Many people say paravertebral blocks are too difficult to perform, but actually you can use benefit to patients. So you can perform analgesic blocks whilst teaching your trainees and getting yourself up that competence ladder. So you can start off with an erector spinae plane block, then when you get good at that, do intertransverse process blocks, and then move on to paravertebral blocks while still allowing your patients to benefit. So in summary, listen to your patient, give them all of the information they need to make a decision, work with your surgeon so that they're happy, tailor your regional anesthetic to each patient, and use at least some local infiltration if you're not going to perform a block. And once you've done all of that, make sure you measure your quality of recovery and then publish your results. I do hope that that was useful, just to show there's a group of patients I've looked after, I had the pleasure of looking after in the past, all with big smiles on their faces, all happy. And this was a tweet from a patient of mine who remembered me on their 5-year mastectomy anniversary because of the positive impact of regional anaesthesia. I do hope that that's been useful and you've been able to take some useful points away from that. Thank you to my patients, to my breast team, and to you for listening. Don't forget, my slides will be available at my SlideShare account, and I will be posting the video soon too. Many thanks.